Good day. This is the second of the series on MCQs because your NEET exam is coming now, and I've been asked by students to look up the previous question papers and to pick up the most important or frequently asked questions in surgery and to make MCQs briefly with explanation. I have made presentations on intercostal tube and tension pneumothorax as longer versions, which are available in the playlist, but these are specifically to be able to answer the MCQs with some amount of clarity. So what are the likely questions? What is the material used? Can be one. And where exactly you insert it? What are the indicators that the lung has expanded? And about the exact technicalities of the intercostal tube. So your first question, the material most commonly used for short-term intercostal drainage. I want you to pick up these small adjuncts. See? Then when you're given an option, you should not have a trouble. Red rubber, very reactive. It was, but used decades ago, so it isn't. Polyvinyl chloride, yes, polyvinyl chloride. Can we use silicon? Yes, you can use silicon because one, it is very flexible. You see how flexible it is. See this, how rigid. The very fact you know it is rigid, this is flexible, but this is expensive and not easily available on a large scale. So that can be used when you have to keep it for a long term, like your bronchopleural fistula and empyema, until you are able to give some sort of definitive interventional radiology or open surgery or minimally invasive surgery. So the question here was short-term intercostal. Keep that in mind. Polyurethane is a material used. It is biocompatible, but it is not used for intercostal tubes. It is used for vascular tubes used in cardiovascular surgery. So the material most commonly used for short term will be polyvinyl chloride, and for long term will be silicon, red rubber and polyurethane. Red rubber given up and polyurethane not used. Red rubber was used when I was a PG, that was about 40 years ago. So the next question regarding the triangle of safety, you want to know the boundaries. There's a detail about this in one of the presentations, which is called tension pneumothorax and ICD in my playlist. Please have a look for greater depth. So what is the options? Anteriorly is the pectoralis minor, posteriorly is the latissimus dorsi, and the base is the fifth intercostal space, and anteriorly is the pectoralis major. Now let's see what's going on. You can see the landmarks yourself. You see, anteriorly is the pectoralis major, correct. Base is the fifth intercostal space. Posteriorly is the latissimus dorsi. Now the answer is the option which is not appropriate is anteriorly is the pectoralis minor. Now have a look. They purposely gave these two to confuse students. Anteriorly is the pectoralis minor. It is still anterior. Nobody is telling no. But it is deeper to the pectoralis major and not available for clinical definition. What will be available will be your pectoralis major. Minor will be beneath it and you cannot palpate or look at the edge clinically. So don't get confused. It is pectoralis major or anterior axillary fold and posterior axillary fold. Purposely, they gave you these two muscles. If they had said anterior axillary fold, you wouldn't have had an issue. They purposely put these muscles to get you into the trap. So always we have clarity. Okay. So all of the following is a good indicator that the lung has expanded and your intercostal drainage tube can be removed. One is clinical expansion of the lung. Yes, you will look for clinical expansion like your air entry, your respiratory rate, and your SpO2. This is the bare minimum clinically. In the air, the water column should be very short. The excursion should be very small. Is it right? We don't know yet. Radiological expansion of the lung. Yes, you can see that the lung is nicely expanded. ICD is still there. You can see the ICD there. But the lung is nicely expanded. No mediastinal shift. Now the column movement in the tube should be at least 10 centimeter excursion. Let's have a look at the videos and probably come back to these slides. You can see the column moving very less. Okay, let's come to the next video. That is where the column is large. See the column? Now, the length of this column depends upon the space occupying problem here. The space occupying problem should be a air here. So the larger the cavity, more will be the column moving. That means lung is not expanded well. This is a reflection of the volume in the pleural cavity. So if the column is moving very high, that means the pleural cavity is still big. If it is big, that means it is filled with air. So that means your lung is not expanded. So the right answer will be small excursion in the tube. Fine. So the following is true of ICDs. Underwater seal is mandatory in all circumstances. You can make out there has been water put there. There's a little bit of blood tinge, but this is the water level. Now this is not true. Why, you know? Because bags have come which have one-way valves. They'll only allow the air to get into the bag. This is very useful when you have to take the medical gear to far-flung places. Hospitals, okay, you can fill it with water. But far-flung places, one, you have to carry the water. Water may not be available. So many other factors may be there. So you would like to carry light equipment, but efficient equipment. So it is not mandatory in, that's why all circumstances. In a hospital, yes. But in a disaster zone or in far-flung areas, there are one-way valve bags available. Tube to be fixed at 5 cm distal to the last inlet or eyelet. These holes are called inlets and eyelets, whatever you want to call. So where exactly you will fix the tube to the skin? This will be in the cavity. And the last eye should be in the cavity. How do you know the last eye is in the cavity? By fixing at 5 cm distal to the eye. The skin, it will be fixed here. See, at 5 cm from the last eye. So if you keep your hand there at 5 cm from the last eye and you push it in, you will know where exactly you can park it and stitch it. Fine. Then fogging in the tube is confirmatory that it is in the pleural cavity. Yes, it is right. Fogging will happen immediately. You can, in fact, you can see the fog there. If you can see the fog, see, this is the fog. See, you can see the fog, and the rest is clear. So fogging in the tube, like your endotracheal tube, it will start fogging the moment you put it in. Tube to be retained until the drainage is 100 ml per day. Yes, that is one of the factors. So what is not true is your underwater seal. That is why the question is in all circumstances. What will happen? The student will be just ready to go and jump and mark this. So be very careful. So in all circumstances, unlikely, all the times, these are the ones which you need to think further. Don't immediately run and jump and conclude this to be true. It may be the answer which is not correct. It is not true. So be careful. You might think, no, this is true, and then you will start going to the rest and trying to find out something to help you. So be very careful and read your STEM. After all, the number of questions will be the same. The concepts in an intercostal tube will be this 4 5 only, but they'll keep on twisting and tweaking and fine tuning these options. That is where students get it wrong. You think I've made that was an intercostal tube drainage, a very simple subject. We have read that 500 times. Why should I not be right? No, they have kept traps in your STEM. So be careful, take your time out to read the STEM. So thank you, and again I'll ask you to subscribe, share and like, and please do join my Telegram channel. Now I've started posting quiz also on the YouTube. Please take some time out and read those questions. They are very, very useful in your MCQs along with explanation. Thank you.